So obviously we have a major problem. The boomers are coming, they're coming along at an extremely rapid rate, and during this time the number of geriatricians has stabilized out and we just don't have enough geriatricians. The hope is that because much of what we do in geriatrics is interprofessional, we will be able to get large numbers of people in the other allied health professions and nursing to come along and fulfill the role of the geriatrician. Because of this, we've developed things like the rapid geriatric assessment, which allows people to do this, and it can be computerized, getting to the stage where it can be done by anyone, not needing to have a specialist geriatrician. So we're doing a number of things. One, we're obviously trying to increase the awareness in the medical school amongst young medical students and residents about geriatrics, and at least give them a basic knowledge. But more importantly, we're focusing on educating a large swath of people who are interprofessionals, who can work on geriatric problems, who can carry out much of the screening, some of the early treatment, and get involved in the lifestyle training that is essential to improve the care of older people. So the main cause of disability is mostly frailty. Frailty is related obviously to deficits that we develop from diseases, but equally to a lack of an active lifestyle that is continuing to keep us muscles strong, to keep our brain strong. And therefore it's this combination. It's the illnesses of aging, the physiology of aging going downhill, but the fact that many of us as we age don't keep ourselves as active as we need to. So we can put together the activity and also work on reducing deficits where possible, where there are treatments available, we will have much better outcomes. Well, when I'm not totally depressed, which are some days, I see that the future is going to be actually really wonderful, but done with a combination of computer-driven assisted diagnosis and management, with allied health professionals taking a major role and doing not only the diagnosis, but carrying through to creating the programs such as cognitive stimulation therapy, such as the exercise programs, such as the socialization programs, all of which are absolutely key to having a high quality at the end of life and throughout our third age. Well, if people listen to me, the answer is it wouldn't impact, but it most probably will. We're in a time where we can't really afford Medicare anymore. And what we have to do is look and say, what are the things that make a big difference? Where should we put our money? Should it go for a $5,000 drug to cure lung cancer? Or should we accept that maybe we're better off focusing on the things such as exercise therapy, cognitive stimulation therapy, adequate nutrition, the Meals on Wheels, for instance, making sure that people are getting a healthy lifestyle and cutting back perhaps a little bit on these extraordinarily expensive drugs that sometimes give you an extra 2 or 3 months maximum. And I think we've got to look and say, if we don't have money, where do we want to put the money? We want to put it into making the pharmaceutical companies even richer, or do we want to put it into the community to improve care for everybody in the community? And obviously I'm biased as a geriatrician, and I think that the money should be going to developing the programs that will help people in the community, will act as the preventive brakes that will cut down the need to go to hospital, will cut down the need for many of these drugs. So I think that, quite honestly, many hospitals are not attuned to how to look after older adults. We actually let them come into a hospital and they lose a kilogram of muscle in 3 or 4 days while they're in hospital. They never get that back. We are not keeping them active in hospital. We're not feeding them properly. We're not necessarily paying attention to the greater geriatric needs, but rather focusing on a single condition. I think that the future should be most probably similar to what's happened in Europe to a large extent, that you have what are almost cottage hospitals, these hospitals where they are for subacute things. So a nursing home that does long-term care with more nurses working there with telemedicine could look after things like urinary tract infections, can look after deep vein thrombosis, most probably even some degrees of myocardial infarction. A lot of things can be treated in a subacute care setting where the costs will be less, where we can, however, improve the focus also on rehabilitation and on providing a geriatric focused care. I have great faith that nurse practitioners are going to be the future of geriatrics. They do a superb job as it is, and with the shortage of geriatricians, I look forward to many of the nurse practitioners being able to do very high quality geriatric care in the future, most probably based on some form of long-term care rather than in a hospital.